Vanakkam. Intrinsic contractures of the hand, or intrinsic plus deformity, or intrinsic tightness. What do you think about it? Isn't it a very complicated problem? Pretty difficult problem to treat, isn't it? It's a rare problem, so why worry about it? That's what we all tend to think. But it isn't true. It is not a complicated problem at all, provided we understand how it occurs, and that we shall see in this video. No, it is not a difficult problem to treat, provided we understand the dynamics of what occurs. And no, it is not a rare problem as we sometimes imagine. So shall we go ahead with understanding the intrinsic contractures of the hand? We all know what is the intrinsic minus hand, where the intrinsic muscles are paralyzed. So what is intrinsic plus hand? Does it mean the intrinsics are overacting? Is it the same as intrinsic tightness and the intrinsic contracture? Yes, indeed. And in this video, we are going to learn all about the intrinsic contractures, the features and the management. And we shall learn about it under the following headings: the anatomy of the intrinsic muscles, the biomechanics of the intrinsic muscles, the pathomechanics of intrinsic contracture, the etiology of the problem, the clinical features that can be seen, and the treatment aspects. We shall first consider the anatomy of the root cause of this problem, the intrinsic muscles. What are the intrinsic muscles? They are small muscles with origin and insertion within the hand itself. They can be the finger intrinsic muscles, which consist of 7 interossei, 4 dorsal and 3 palmar interossei, 4 lumbrical muscles and the hypothenar muscles, and thumb intrinsics consisting of 4 muscles: the opponens pollicis, the abductor pollicis brevis, the flexor pollicis brevis and the adductor pollicis. There is one very interesting common feature among all these intrinsic muscles. The interossei muscles arise from the shaft of the metacarpals and insert into the extensor expansion, and they cross the metacarpophalangeal joint on the volar side. The lumbrical muscles arise from the FDP tendons of the individual fingers and insert onto the radial lateral band of the extensor expansion, and they too cross the metacarpophalangeal joint on the volar side. The hypothenar muscles arise from the carpus and the volar aspect of the base of the metacarpals 4 and 5 and insert onto the PPX of the little finger across the metacarpophalangeal joint and cross it on the volar side. And the thenar muscles are somewhat similar. They arise from the metacarpals and insert into the PPX of the thumb, and here too they travel volar to the metacarpophalangeal joint of the thumb. All this has a role to play in the biomechanics of intrinsic muscle action. We shall be mainly considering the biomechanics of the interossei and lumbrical muscles of the fingers. We have already seen that these muscles run volar to the axis of the metacarpophalangeal joints, but we need to note that they are volar to the axis of the rotation of the metacarpophalangeal joints but dorsal to the axis of rotation of the interphalangeal joints. Let us see how. If this represents the metacarpal bone and these the phalanges, the intrinsic muscles can be represented like this at the level of the palm. The tendons of these muscles run volar to the metacarpophalangeal joint and run dorsally to get inserted along with the long extensor tendon slips to form the central slip and getting inserted into the base of the middle phalanx. This represents the transverse fibers and the oblique fibers of the extensor expansion. Here you can note that the tendons of the intrinsics run volar to the axis of the metacarpophalangeal joint and dorsal to the axis of the proximal interphalangeal joint. So when this muscle contracts, it causes metacarpophalangeal joint flexion and interphalangeal joint extension. To understand this better, I have shown a representation on my hand showing that the metacarpophalangeal joint flexes and the interphalangeal joint extends on contraction of the interossei muscles. Similar to the function in the fingers, the intrinsics of the thumb produce flexion of the metacarpophalangeal joint and extension of the interphalangeal joint. Here in this picture, you can see a hand with paralysis of both the median nerve and ulnar nerve, showing hyperextension at the metacarpophalangeal joint and flexion at the interphalangeal joint. The actual power of the hand depends on metacarpophalangeal joint flexion. In fact, in intrinsic minus hand, where there is no primary flexion of the metacarpophalangeal joints, the patient will typically complain of loss of strength. It has been noted that intrinsic muscles account for approximately 53% of the grip strength and 85% of the pinch strength in the hand. So when dealing with these intrinsic muscles, we need to remember that they are very strong muscles. When such powerful muscles become shortened, what happens? So we shall now see the dynamic effects that can be caused by contracture of these muscles or shortening of these muscles. When the intrinsic muscles are acting well and are normal, we will be able to do extension of the metacarpophalangeal joint and flexion of the interphalangeal joints. This puts the intrinsic muscles into maximum stretch. The ability to perform this hook movement indicates that the intrinsic muscles are intact and supple. When holding the metacarpophalangeal joint in extension, if the patient finds it difficult to flex the interphalangeal joints actively, it indicates that there is tightness of the intrinsic muscles. If the metacarpophalangeal joints of the fingers are in a position of flexion and the patient is not able to extend the metacarpophalangeal joints actively, it indicates that there is a contracture of the intrinsic muscles. So we have seen what is the intrinsic tightness and what is an intrinsic contracture. Both these constitute what is known as the intrinsic plus hand. So what conditions can cause intrinsic plus hand? That brings us to the etiology of intrinsic contractures. It was in 1920 when the first description of the intrinsic hand contracture was presented by Finocchiaro, and in 1946 Sterling Bunnell gave the expanded clinical features describing that the intrinsic contracture occurred due to ischemia. But better understanding of the intrinsic contracture has shown that there are multiple etiologies. Trauma, vascular injuries, rheumatoid arthritis, some congenital conditions, neurologic pathology and iatrogenic causes can cause intrinsic contractures. Trauma is one of the commonest causes. Fractures of the hand bones like the phalanges, metacarpals and distal radius may cause intrinsic tightness due to edema and immobilization. Adhesions and fibrosis of the tendons and muscle bellies leads to fibrosis of the intrinsic muscles also. Vascular injuries and vasospastic conditions may also cause intrinsic tightness and contractures, like in this patient who has already had a gangrene of the ring and little fingers and residual raw areas on the index, mid and thumb. In these patients, compartment syndrome of the hand and vascular injuries cause contractures through ischemia. Partially or completely functionless fibrotic muscle tissue will result replacing the intrinsic muscles. In rheumatoid arthritis too, intrinsic tightness and intrinsic contractures can occur. The resulting swan neck deformity can occur due to adhesions, muscle spasm from local inflammation or contracture from decreased movements. In some congenital conditions like Friedman-Sheldon syndrome, the hand assumes a rheumatoid posture with flexed and ulnarly deviated metacarpophalangeal joints. Neurological pathology like cerebral palsy, stroke, tetraplegia and traumatic brain injuries can also lead to intrinsic contractures where the muscles are acting but spastic. Iatrogenic causes like tendon transfers done for claw correction can result in intrinsic contractures if the tensioning for the claw correction has been too tight. If there are so many etiologies, what are the clinical findings? And how do we diagnose and evaluate these problems? Patients will most commonly present to the hospital with disability due to inability to open the hand and hence difficulty in grasping larger objects, and sometimes in severe intrinsic contractures, difficulty in maintenance of hygiene. When we clinically examine the patient, in mild cases, patient will not be able to flex the proximal interphalangeal joint when the metacarpophalangeal joint is extended. In this patient who has had an EF40 procedure, that is a procedure for claw correction, the middle finger, you will note, he is not able to flex the PIP joint when the metacarpophalangeal joint is extended. So this is a mild case of intrinsic tightness of the middle finger alone. In moderate cases, the patient will not be able to extend the metacarpophalangeal joints fully and tightness will be palpable in the palm. And in severe cases, the hand will be in a position of hyperflexion at the metacarpophalangeal joints and hyperextension at the proximal interphalangeal joints. As far as the thumb is concerned, there will be an adduction contracture because of the fibrosis of the adductor pollicis muscle. When the condition is a little more severe, there would be a flexion contracture at the metacarpophalangeal joint of the thumb too. But these are in the established cases of intrinsic tightness or contracture. How do we diagnose a very mild tightness of the intrinsics? Is there any test to do so? Yes, the intrinsic tightness test described by Bunnell. First, hold the metacarpophalangeal joint of the finger in extension and ask the patient to flex the interphalangeal joints. He will not be able to do so, or it will be very difficult in intrinsic tightness. However, when we flex the metacarpophalangeal joint, patient will be able to very easily flex the proximal interphalangeal joint. This shows that the intrinsic muscles have been slackened by flexing the metacarpophalangeal joint. We have seen the intrinsic tightness test. Let us see the extrinsic tightness test just to understand the difference. Here the metacarpophalangeal joint is kept in flexion. The patient will not be able to flex the interphalangeal joints or will find it difficult. But when we place the metacarpophalangeal joint in extension, patient will be able to very easily flex the interphalangeal joints. This indicates tightness of the extrinsic extensor tendons. Having made a diagnosis of an intrinsic tightness or a contracture, we need to proceed and evaluate the hand further. We need to assess the passive and active motion of all the joints. We need to do a rheumatologic laboratory testing in cases of rheumatoid arthritis, and in spastic patients, brachial plexus nerve block before the intrinsic tightness test will show whether it is an increased muscle tone or spasticity or a fixed contracture. Now it is time to take a decision and treat the problem. The treatment may be non-surgical or surgical. The non-surgical method of management may be preventive or therapeutic. Let us consider first the non-surgical measures taken for prevention of development of intrinsic muscle tightness. Following any trauma to the hand, limb elevation and early digital motion exercises are very important because persistent edema leads to serum protein deposition and subsequent scar tissue formation. Anti-edema measures will help to a great extent. When we have begun to realize by our clinical examination that the intrinsic muscles are getting tight, we need to institute the non-surgical therapeutic techniques. The first is manual stretching of the intrinsics. Here, passively placing the metacarpophalangeal joints in extension and interphalangeal joints in flexion will help to keep the intrinsic muscles stretched. This patient, 3 months since he had sustained burns on the left hand, is beginning to develop intrinsic tightness. The priority before reconstruction of the skin here would be the release of the intrinsics. Under anesthesia, the metacarpophalangeal joints of the fingers were stretched and immobilization done of the metacarpophalangeal joints in extension, allowing interphalangeal joint flexion. Progressive static splints, which are custom fitted to hold the metacarpophalangeal joints in extension and stretching, can be performed by PIP joint active and passive hook exercises. The use of the reverse knuckle bender splint will help. flexible swan neck deformities, which is an intrinsic tightness of the extensors in the finger, may be treated with a figure of 8 splint or a silver ring splint, and for patients with spasticity, antispastic medication or injecting botulinum toxin can improve the symptoms. But these have been for mild tightness of the intrinsics of the hand. What do we do when there is an established intrinsic contracture? Let us consider the surgical means of management. There are many different techniques, so the decision would have to be made based on the etiology, the severity of the problem, the duration of symptoms, and the joints that are involved. I shall describe all the options one by one and then finally discuss which procedure needs to be done for which condition. First, we shall consider the distal intrinsic release. This is indicated for mild cases, and resection of the ulnar or radial side lateral bands can improve the proximal interphalangeal joint range of motion. As we have seen, in the mild cases, it is only the proximal interphalangeal joint that is involved. When the metacarpophalangeal joint flexion contractures are present, this distal intrinsic release will not be adequate. By a single midline dorsal incision or a double midaxial incision, increasing amount of oblique fiber tissue is resected, and the amount of resection is determined by the degree of PIP flexion during repeated intrasurgical intrinsic tightness tests. There is a slight modification of this procedure known as the radial lateral band resection. This is indicated when only the lumbrical is involved. This situation usually occurs in a condition known as a lumbrical plus finger, where paradoxical extension of the interphalangeal joints while attempting to flex the fingers occurs. That is, extension of the interphalangeal joints of one digit with attempted flexion of all the fingers. This usually occurs in neglected flexor tendon injuries. In this procedure, the radial side lateral band can be transected at the origin in the palm, that is a proximal release, or at the insertion on the dorsal apparatus, which is a distal release. We shall now consider a procedure called intrinsic tenodesis. When there is a tightness of the proximal interphalangeal joint, irrespective of the position of the metacarpophalangeal joint, this procedure is indicated. In this situation, there is a chronic hyperextension of the proximal interphalangeal joint, the volar plate is attenuated, and the collateral ligaments are tightened in shortened position. So first, a dorsal capsulectomy, collateral ligament release is required to address the joint contracture, and then the tight intrinsic tendon is released proximally. The lateral band is then dissected and divided. It is brought volar to the Cleland's ligament and secured to the proximal phalanx to constitute a tenodesis. In a similar procedure called lateral band translocation, the lateral bands are translocated volarly. This is done through a midlateral incision on the radial side of the digit. The lateral band is dissected and released as done for the previous procedure and retained on the volar side by raising a dorsally based 1 cm flap of flexor sheath, which is then sutured back after retaining the translocated lateral band. There is a simpler procedure called lateral band mobilization. This is indicated in rigid swan neck deformity. Here, adhesions within the lateral bands with the extensors and the joint capsule are very common. So release of all these adhesions with an extensor tenolysis, dorsal capsulectomy and lateral band mobilization needs to be done, and it may require an arthroplasty also. By a single dorsal incision, both the lateral bands are released from the central slip and the triangular ligaments. So now the lateral bands become volar to the axis of the PAP joint and flexion can be achieved. Crossed intrinsic transfer is a procedure indicated in advanced rheumatoid arthritis. The actual procedure indicated in this condition would be silastic interposition arthroplasty to correct the problem of ulnarly deviated fingers at the metacarpophalangeal joints. Along with this procedure, a crossed intrinsic transfer is done to maintain the correction achieved by silastic interposition arthroplasty. In this procedure, by dorsal exposure, the ulnar side interosseous tendons of the index, middle and ring fingers are cut and dissected proximally up to the muscle bellies. These divided tendons are then rerouted and secured to the radial sides of the adjacent ulnar digits. There are some situations where a procedure called the proximal interosseous muscle slide is indicated, like lesser deformities, and there is some remaining function of the intrinsics. There could be spasticity also. Here, by a distal transverse palmar incision, the origins of the interossei are elevated, and then the metacarpophalangeal joints are extended passively and splinted in full extension, which allows the origin to heal in a new distal position. When the intrinsic muscles are contracted but still functioning, a procedure called the interosseous tendon fractional lengthening can be done. By a transverse palmar incision, the tendinous portion of the myotendinous junction of the interosseous muscle is incised, leaving the muscular portion intact. This will help the interosseous muscles to lengthen for a certain extent so that the intrinsic contracture can be overcome. Of course, this procedure is difficult owing to the depth of the volar interossei and the short myotendinous junctions. In the beginning, we saw the distal intrinsic release. Now we shall see the proximal intrinsic release. This procedure is indicated as a salvage procedure for contracted and non-functional intrinsics. It will correct fixed flexion of the metacarpophalangeal joint and extension of the proximal interphalangeal joints. What we will be releasing are the transverse and oblique fibers of the intrinsic mechanism proximal to the metacarpophalangeal joint, and hence the action of the intrinsic muscles is eliminated. Finally, the procedure of ulnar neurectomy also has a role to play in the treatment of intrinsic tightness and contractures. It is indicated for spastic patients in whom volitional control is absent, and surgical denervation will help to paralyze the intrinsics and allow easier hygienic care. This can be done by dividing only the motor branch of the ulnar nerve distal to the Guyon's canal. We have already seen this example of a patient with an intrinsic contracture on the thumb and fingers. For this patient, a proximal intrinsic release of the abductors of the thumb, the adductor pollicis, and the interossei and lumbricals for the fingers was done to achieve full extension of the metacarpophalangeal joints and supple passive flexion of the proximal interphalangeal joints. The resulting function of the thumb and fingers at the end of 1 month can be seen here. Similarly, in this patient who had a vascular injury, subsequent gangrene of the thumb and reconstruction with the flap cover, had intrinsic contracture of the index, middle, ring and little fingers. A transverse palmar incision was marked, and through this proximal intrinsic release of all the fingers was done, and full metacarpophalangeal joint extension and passive PIP joint flexion was achieved by the procedure. A POP was applied, keeping the metacarpophalangeal joints in full extension, leaving the interphalangeal joints free for flexion, and this shows the results at the end of a month. Having learnt all the procedures, let us now summarize and see which procedure is indicated for which condition. If there is only PIP joint tightness, a distal intrinsic release is indicated. If there is PIP joint tightness with the stiffness of the joint, lateral band tenodesis, translocation or mobilization procedure will be indicated. If there is tightness of both metacarpophalangeal and proximal interphalangeal joints, proximal intrinsic release should be done. When both the metacarpophalangeal and proximal interphalangeal joints are tight, but the muscles are acting, fractional lengthening or interosseous muscle slide procedures can be done. If there is a severe contracture preventing hygiene, a proximal intrinsic release along with ulnar neurectomy is indicated. So, as far as tightness of the intrinsic muscles of the hand is concerned, it is very important to prevent it from occurring. And if it occurs, it is very important to recognize it early. And if the tightness is established, it is important to correct the problem and restore function. I hope you liked the video. I enjoyed making it. Please click on the shown links to see other videos about fracture management, flexor tendon healing and repair, and other such surgeries on the hand. And do not forget to subscribe to stay connected with the latest in learning hand surgery, plastic surgery, trauma surgery and ethics. Vanakkam.